So good afternoon. It's my pleasure and honor to welcome you all. And on behalf of the Cancer Research Group, collaborative group represented by its president, Dr. Fadi Farahat, we are organizing with Arab Medical Association Against Cancer the 2023 ABC Oncology Educational Course. The course will tackle different modules, and each module will consist of 2 to 3 webinar sessions, which will be scheduled every week. This series of meetings will be accredited and supported by the Arab Medical Association Against Cancer, AMAC, and will be endorsed by the Union of International Cancer Control, UICC, and the American Society of Clinical Oncology, ASCO. The webinar of today, as the first webinar, will be about the role of immuno-oncology in the early stages of cancers. So I will let you with Professor Fadi Farahat to share the sessions. Professor Fadi, he is Professor of Medical Oncology and Head of Hematology Oncology Division at Hammoud Hospital University Medical Center in Saida, Lebanon. So, Dr. Fadi, please, the floor is yours, and you are welcome.
Thank you, Dr. Sami, for the introduction. Thank you for my colleagues for the support in tackling a nice topics, which is the immunotherapy in early stages of cancer. We will not approach all stages, all diseases, but we will take the most important. So I'm very pleased to have the 3 eminent speakers. Dr. Fadi Karak, Professor Fadi Karak from Hotel Dieu de France, Liban, and CMC Dubai. So we consider him as Libano-Dubai man. Dr. Sally Tamraz, Professor Tamraz, also from the American University of Beirut, and Dr. Professor Hamdi Abdul Azim from Cairo Care. So we will start with the first topic, Dr. Fadi Karak, and we will be talking about the early stages of lung cancer and the role of immunotherapy as breakthrough. Thank you. The floor is yours, Dr. Fadi.
Doctor, please, you are muted.
Good evening. Thank you, Dr. Farhad. Thank you, Dr. Khatib. I'm so glad to join you during this session. Very, very interesting topic, immunotherapy in early stages of cancer. So Dr. Farhat asked me to talk about immunotherapy in early stage non-small cell lung cancer and in small cell lung cancer, but unfortunately, all the work have been done till now in early stages in non-small cell lung cancer. So I will start just by a definition. What is early stage non-small cell lung cancer? And that's easy to define because early stage non-small cell lung cancer are patients who don't have metastasis, so it's not M1 disease. Patients who don't have M3 disease, it means patients don't have contralateral mediastinal lymph nodes, and patients who don't have very small cancer like tumor less than 2 centimeters and no nodes. So this is a very easy way to define early stage non-small cell lung cancer. So mainly these are patients with hilar lymph nodes or with ipsilateral mediastinal lymph nodes, or even tumor without lymph nodes, but patients who have a tumor more than 4 centimeters. So this is the definition of early stage non-small cell lung cancer. I will start with just a course on history about how we usually were dealing with early stage small cell lung cancer. In like 5-6 slides, I will just give you a resume about how we were dealing with these cancers. So usually we were giving patients adjuvant chemotherapy after surgery for non-small cell lung cancer. And the chemotherapy added benefit for at 5 years survival. For stage 1, we just gain around 4%. For stage 2, we gain around 10 to 12% in overall survival at 5 years. And for stage 3, whenever you get chemotherapy after surgery, you get around 15% of increase in the overall survival. And that's huge. That's why the standard of care was till recently just surgery followed by 4 cycles of platinum-based chemotherapy. If you want to know about what chemotherapy you should use, the huge body of evidence was based around the vinorelbine and cisplatin. This is a big study of Thierry Le Chevalier from Institut Gustave Roussy. And patients should get at least 300 milligram per meter square of cisplatin, which is at least 3 cycles of 100 milligram per meter square of cisplatin. Then we tried to use neoadjuvant chemotherapy, and here is a Kaplan-Meier curve of what neoadjuvant chemotherapy can add on the survival of patients before getting surgery. So you can get around 5% at 5 years increase in overall survival for stage 2 and 3 disease. So it's almost the same benefit as the adjuvant treatment. But we oncologists, we love to do neoadjuvant treatment. So patients with stage 3A or stage 2, usually we were starting with just neoadjuvant chemotherapy before surgery, and that's the practice of almost everybody. One word about adjuvant radiotherapy, just want to remind you because that's a new data. Radiotherapy in the Porte trial, it was a negative trial. So adjuvant radiotherapy for lung cancer, it worsened the survival, except for stage 3A. So if you look at this trial of postoperative radiotherapy for stage 3 and 2 disease, you gain around 5% by adding adjuvant radiotherapy. Lately, Cécile Le Péchou did this publication in the Lancet Oncology 2021, where she took only patients with stage 3A disease, and she prospectively randomized these patients into conformational radiotherapy or control, and the study was negative. And if you just get a second opinion of the role of adjuvant radiotherapy for non-small cell lung cancer, even for stage 3A and 2 disease, the recommendation would be don't give adjuvant radiotherapy, especially if the surgery is well done and there is good mediastinal staging. So that's the background. That's how we were treating our patients up till now, until the era of immunotherapy. And the first study of immunotherapy in lung cancer was inspired from the trials of immunotherapy in prostate cancer. And you know that there is a vaccine for prostate cancer that it's FDA approved, and it's enlisted in the NCCN guidelines. This is a kind of vaccine. And in lung cancer, they tried to use this vaccine with MAGE-A3. This is the antigen they're giving their patients. It's intramuscular injections, 13 intramuscular injections over 27 months after surgery. And the study is clearly negative. You cannot get 2 survival curves superimposed like what we're seeing in the curve disease-free survival, curve A. So the study was negative, and the vaccine trials were just left from development in non-small cell lung cancer. Then was the era of checkpoint inhibitors. And the most advanced trial was this one, the Checkmate 816. So I will elaborate on this study because the drug now is approved and we are with Lebanon. So patient with non-small cell lung cancer, stage 1B to 3A, so tumor more than 4 centimeters without lymph nodes, up to patients with ipsilateral mediastinal lymph nodes. They were randomized into two groups, either 3 cycles of chemotherapy alone or 3 cycles of chemo 360 milligram every 3 weeks. It's not every 2 weeks. It goes with the cisplatin regimen. So it's 3 cycles of chemotherapy, platinum doublet, and nivolumab, followed by surgery. And the primary endpoint of the trial was pathologic complete response and event-free survival. And here is the primary objective of the trial, which is the pathologic complete response. And that's very impressive in non-small cell lung cancer, where we used to have around 2% of pathologic complete response with chemotherapy alone. Now we're having 25%, so around a quarter of our patients with non-small cell lung cancer who get chemotherapy and nivolumab, they will get a full pathologic complete response. This pathologic complete response, you can get it irrespective of the PD-L1 status. You can see it's irrespective of the PD-L1 status and irrespective of if it is squamous or non-squamous histology. It's irrespective of the stage. Even patients with stage 1B can get such kind of a huge increase in pathologic complete response. Why they focused in lung cancer on pathologic complete response? Because they published in the ASCO 2022, like 1 year later, they published this data about the correlation between pathologic complete response on chemoimmunotherapy and the event-free survival. And you can see these spectacular curves, patients who develop pathologic complete response with chemoimmunotherapy, they have 93% to be event-free at 2 years. And this are very impressive curves. And this improvement in event-free survival, whenever you get pathologic complete response, is irrespective of PD-L1 status. So it doesn't matter if your PD-L1 is positive or negative. If you get a pathologic complete response on chemoimmunotherapy, you will have a chance of being event-free at 2 years, around 90%. And then they gave us, during the same ASCO 2022, I don't know if you had the opportunity to be at the ASCO last year. So they gave us also this impressive data about the value of major pathologic response. The definition of major pathologic response is the presence of viable tumor cells at the time of surgery of less than 5%. So less than 5% of viable tumor cells at the time of surgery. And you can see that almost half of the patients who get chemoimmunotherapy before surgery, they will get this major pathologic response. And if you're getting this major pathologic response, your event-free survival at 2 years is 90%. So the objective now in the treatment of our patient is just to get major pathologic response, or of course better pathologic complete response, and you will have the opportunity of being event-free more than 90%. The risk of complications does not increase whenever you add immunotherapy to chemotherapy. So the risk of wound complication, pain after surgery, procedural pain, fever, pneumonia, because we're always afraid of pneumonitis related to immunotherapy, is not increased whenever you add immunotherapy. It's just like you're getting just chemotherapy before surgery. So the drug was approved and we are now using it. It's approved in Europe and it's approved in the United States. 3 cycles of nivolumab and chemotherapy is now the standard of care for patients with stage 1B to 3A non-small cell lung cancer. Many other ongoing phase 3 trials are used now, like pembrolizumab is doing the same kind of trial. So 3 cycles of chemotherapy and pembrolizumab versus chemotherapy alone. This is the Keynote 671. Durvalumab is trying to do this also, chemo and durvalumab as neoadjuvant treatment. Atezolizumab is doing the same trial. It's the Empower 030, but the results are still awaiting. I will move to the adjuvant trials, immunotherapy in the adjuvant setting in early stages of non-small cell lung cancer. So here the most advanced trial is the trial with Tecentriq. So it's the Empower 010. So patients with stage 1B to 3A. So the same inclusion criteria. Patients who get surgery first, then you can get adjuvant chemotherapy. That's the standard, 4 cycles of adjuvant chemotherapy. And patients are then randomized into nothing, just watch and wait, or atezolizumab for 1 year, like 16 cycles every 3 weeks. The primary objective of this trial was the disease-free survival in stage 2 and 3A. So not stage 1B, stage 2 and 3A, and patients who have PD-L1 more than 1%. And if this analysis turned out to be positive, so the investigator would have to investigate the value of immunotherapy, 1 year of atezolizumab for stage 2 and 3A, but irrespective of PD-L1. And if it is positive, then they will go into the intent to treat population, which are patients with stage 1B to 3A, irrespective of PD-L1. And here is a primary objective, which is the disease-free survival for patients with PD-L1 more than 1%, stage 2 and 3A. And here you can see that we have around 13% increase in the disease-free survival. The hazard ratio is 0.66. That's a positive, and it crossed the significance boundary. So they moved to the secondary, second primary objective, which is the increase in disease-free survival for patients with stage 2 and 3A, irrespective of PD-L1. Here you can see that almost 9% increase in the disease-free survival at 2 years. The hazard ratio is 0.79, but unfortunately it didn't cross the predefined significance boundary. So they stopped the analysis, and now the drug is approved also for in the adjuvant setting for patients with stage 2 or 3A, non-small cell lung cancer, resected patients with PD-L1 more than 1%. The data on overall survival is still immature, and we're still waiting for it. You all know the safety profile of Tecentriq, and it's the usual, it's minimal. We all know how to handle the toxicity of Tecentriq as monotherapy in non-small cell lung cancer. Many other ongoing phase 3 trials on adjuvant checkpoint inhibitors are now on the way. Unfortunately, we will soon be confronted to plenty of options, and we oncologists, we will not know exactly what to do. So the patients can just see 3 oncologists and get 3 different opinions. So patients can tell, physician can tell their patients, go get 3 cycles of neoadjuvant chemotherapy and nivolumab. Other physicians will tell the patient, go do surgery, and then you will get Tecentriq for a year. And now these ongoing trials, you can see that we have the option of doing neoadjuvant chemoimmunotherapy followed by adjuvant immunotherapy. And unfortunately, we will not know exactly what to do in the near future. So as a summary for how to guide the treatment in non-small cell lung cancer in early stage disease. So if you have an early stage non-small cell lung cancer patient, you don't have to test for PD-L1. You just have to know that your patient has a tumor more than 4 centimeters or node positive, and then give your patients 3 cycles of neoadjuvant chemotherapy and nivolumab, followed by surgery. Or you can tell your patient, just go do your surgery. If your PD-L1 is more than 1%, then you can get adjuvant atezolizumab for 1 year. As a conclusion for how we treat our patients with early stage non-small cell lung cancer, neoadjuvant and adjuvant chemotherapy give your patient around 5% increase in overall survival at 5 years. It's comparable effectiveness. You can do whatever you want. Adjuvant chemotherapy can be given to patients with stage 1B with tumor more than 4 centimeter, 2 or 3. You should give cisplatin more than 300 no role for perioperative radiotherapy. I couldn't help myself to put the note also that we have also the option of giving our patient adjuvant osimertinib. That's targeted therapy, but I should put it somewhere because that's also standard of care. As for checkpoint inhibitors, so there is a benefit in pathology complete response after neoadjuvant chemotherapy and immunotherapy. There is increase in disease-free survival when you add adjuvant atezolizumab. We're still awaiting for the overall survival result. We don't know the best scheduling, whether we should do neoadjuvant immuno, we should use a combo of chemoimmunotherapy, or we should use adjuvant immunotherapy. And this will have to be defined later on. And thank you again. I'm ready for any question if the moderators want questions to be done right now.
دكتور سامي تفضل. Okay, thank you very much, Professor El-Karak, Fadi El-Karak. Thank you. It's very amazing where we are moving in lung cancer. I will see if there's a question from the audience. For the time being, no questions. I would like to ask you, in case we are using neoadjuvant or adjuvant, let's say neoadjuvant treatment, and we have a relapse. It will be like another indication. We will wait 1 year. If the relapse is less than 1 year, no immuno, more than year, we can re-challenge with immuno. Do we have any data? And what's your personal opinion?
Dr. Farhad, that's an amazing question. So we have focused this issue for patients with stage 3B disease with durvalumab. So you know that patients with stage 3B disease, they will get concurrent chemoradiation followed by durvalumab. And the question was, if your patient relapsed after durvalumab, what you should do? So I had the opportunity to review this data with one of my fellow, and we sent a letter to the editor for Annals of Oncology because the data was published there, just to give like a guidance what we should do. And the result, if I want to summarize, 6 months. So we have data if you relapse more than 6 months, maybe it's of value to re-give immunotherapy again. And we have some trials that answered this question for stage 3B who received 1 year of durvalumab. I would do the same for the neoadjuvant or adjuvant treatment in lung cancer, although there is no data till now in the early stage. We have some data for stage 3B disease.
Okay, any question from the panelists, from the audience? Okay, if not, another question. The impression in general was that the PD-L1 and PD-1 really differs in efficacy. So in your opinion, if we use, let's say, atezolizumab in adjuvant, and there is a relapse less than 6 months as per review, your letter, congratulations for it. Do you think we can switch to the Ananti from the other group, I mean, from PD-L1 to PD-1, because we have some doubt of the efficacy of one of these groups. Will not go more in details. You understand very well what I mean by that, but is there any crossover resistance between these two groups, in your opinion?
Of course, I don't have a scientific answer on such a question, but I would change I would change treatment. That's what I would do. If I have to do another immunotherapy after 6 months of stopping immunotherapy, I would change a drug, but it's not a scientific answer.
Yeah, no data. Okay, thank you very much. Okay, I think there is Dr. Sami. Thank you, Dr. Fadi, Professor El-Karak from Dubai, from Lebanon. I don't know where you are now. So thank you very much. And we will move to the next presentation with Dr. Sally Tamraz. Dr. Sally is a known medical oncologist in the American University of Beirut Medical Center. She's associate professor. She's very active in the field of research also, and she's more specialized in GI and GU. Welcome, Dr. Sally, and please, the floor is yours.
Thank you, Dr. Farhat, and thank you for the kind invitation for the organizers. Okay. Okay. So as mentioned in the title, I will be discussing mainly the use of immune therapy in GU and upper GI cancers. This is quickly a brief outline of the presentation that I will be tackling. The goals of adjuvant therapy in general, adjuvant, neoadjuvant immune therapy in GU and upper GI cancers. So in general, what are the goals of adjuvant therapy? Well, the purpose of adjuvant therapy given after curative intent of the primary is to reduce the risk of local and distant recurrence and ultimately improve overall survival. However, recently, trials in oncology have highlighted three important issues pertaining to adjuvant therapy in cancer. First, is it good enough to improve disease-free survival if that does not ultimately translate into overall survival benefit? Second, what magnitude of disease-free survival benefit should we pursue? And third, should we use adjuvant therapies without randomized controlled trials? Now, although adjuvant therapies have commonly been used in certain malignancies like lung cancers, breast cancers, colorectal cancers, evidence that their use is associated with overall survival benefit is not always there. So improving disease-free survival from the time of removal of the primary tumor till disease recurrence or death has been shown to be sometimes a surrogate for overall survival. However, these correlations are not always there. For example, improving disease-free survival in the adjuvant setting has been shown to be a good correlate to overall survival in lung cancers and colorectal cancers, but not in breast cancers. So without these significant correlations, really improving disease-free survival without improving overall survival provides a poor risk to benefit trade-off to the patient. Now we move to the role of immunotherapy in early stages of breast cancer. We know that muscle-invasive bladder cancer accounts for about 30% of all urothelial cancers. These are highly aggressive malignancies that tend to recur despite aggressive radical surgery because of the presence of micrometastasis. For this reason, we use neoadjuvant cisplatin-based combination chemotherapy to target these micrometastases and ultimately improve overall survival. In fact, neoadjuvant chemotherapy is actually the standard of care in this setting. Now, if we look at the table on the right side, you can see the approximate systemic recurrence rates following radical cystectomy. So in patients with PT2 disease, it is around 20 to 30%. This jumps dramatically to over 50% in patients with PT4 disease or node-positive disease, underscoring the importance of using neoadjuvant chemotherapy. However, there are important caveats. So neoadjuvant chemotherapy indeed improves overall survival. However, it is underutilized, where only about 20% of eligible patients receive it, 50% being ineligible to it, and 30% refuse it. Pathological CR rates account for about 30% of all patients receiving neoadjuvant chemotherapy. However, 70% of patients may end up with residual disease following surgery. There is currently no standard adjuvant approach if residual disease is present despite neoadjuvant chemotherapy, and there is currently no standard adjuvant approach if neoadjuvant chemotherapy is not offered and the patient is upstaged to muscle-invasive bladder cancer. So again, the goal is to try to eliminate residual cells, reduce the risk of relapse, and improve overall survival. It is important to note here that in metastatic urothelial cancers, immune checkpoint inhibitors have shown efficacy in the platinum refractory setting and in the first-line switch maintenance setting, suggesting a potential for sequential efficacy. Now, if you look at the cartoon below, you can see that urothelial cancers may respond to chemo alone, to CPIs alone, or to a combination of both. And in fact, it's important to note here that there has been a number of trials evaluating adjuvant chemotherapy in bladder cancer that did not prove to be as effective as the neoadjuvant chemotherapy trials. Now, who are the high-risk patients in muscle-invasive bladder cancer? Well, there is a standardized definition used across the different trials that have evaluated adjuvant immune therapy. And all of these trials actually used PT2, PT4A or node-positive disease for patients previously treated with neoadjuvant chemotherapy, or those with PT3, PT4A or node-positive disease who were not treated with prior neoadjuvant chemotherapy. So there are 3 key adjuvant immune therapy trials in bladder cancer. So the CheckMate 274 that compared adjuvant nivolumab versus placebo, the IMvigor 010 comparing adjuvant atezolizumab versus observation, and finally the Ambassador trial, which has just completed accrual comparing adjuvant pembrolizumab versus observation. You can see that all of these trials differ actually in terms of the checkpoint inhibitor being used, PD-1 versus PD-L1, as well as the comparator arm, placebo versus observation. Now, let us start by taking a quick look at the CheckMate 274 trial. So the CheckMate 274 is a randomized, double-blind, multi-center, placebo-controlled trial of adjuvant nivolumab in high-risk muscle-invasive bladder cancer. If you look at the patient population here, you can see that they actually included patients with residual PT2, PT4A or node-positive disease, where prior neoadjuvant chemotherapy was given, or patients with PT3, PT4A or node-positive disease, where prior neoadjuvant chemotherapy was not administered. So as you can see here, they actually included a high-risk population of patients whose systemic risk of recurrence is more than 20% and 5-year overall survival less than 60%, suggesting that there is a high unmet need in this patient population. So patients were then randomized in a 1-to-1 ratio to receive either nivolumab versus placebo. The trial was blinded, which means that patients did not know whether they were receiving nivolumab or a placebo. The primary endpoint of the trial was disease-free survival in both ITT population and in all randomized patients with tumor PD-L1 greater than or equal to 1%. Now, looking at the baseline demographics for patients included in the trial, you can see that they are more or less well-balanced between both arms. Now, let us take a closer look at the primary endpoint of this trial. So on the left side, you can see the ITT population, where the median disease-free survival was 22 months in the nivolumab arm versus 10.9 months in the placebo arm, for a hazard ratio of 0.71 and a statistically significant p-value. On the right side, you can see the PD-L1 positive group, where the median disease-free survival was 52.6 months in the nivolumab arm versus 8.4 months in the placebo arm, for a lower hazard ratio of 0.52. And I will argue here that these results that we are seeing are highly clinically and statistically significant. And in fact, the most important thing with these data is that the curves do go apart, as you can see here, particularly the PD-L1 positive curves, and they stay apart. Now here, an important question arises. Do we think that the PD-L1 positive group with a hazard ratio of 0.52 will ultimately translate into overall survival benefit? I think it probably will, but remember one point, that chemotherapy before had a similar hazard ratio for disease-free survival, but it did not translate to overall survival benefit. So really there remains too many questions unanswered. Now, looking at disease-free survival across selected subgroups, I think we can find these data to be quite reassuring. Again, the majority of patients on the trial did derive benefit from adjuvant nivolumab. Again, the second progression-free survival was also statistically significant, favoring nivolumab in both the ITT population and in those with PD-L1 greater than or equal to 1%. Now, with regards to safety, the safety profile and tolerability of the drug was actually consistent with that reported in previous trials. The most important treatment-related adverse events of any grade were pruritus occurring in around 23% of patients, followed by fatigue in 17%, diarrhea in 16%. And the most important grade 3 or more treatment-related adverse events were elevations in serum levels of amylase occurring in 5%, lipase 3.5%, and in 1% of patients there were diarrhea, colitis, pneumonitis. And overall, we can see that grade 3 or more adverse events occurred in around 42% of patients receiving nivolumab. With regards to quality of life, you can see that there was no meaningful difference in deterioration in quality of life parameters between patients receiving nivolumab and those receiving placebo in both treatment groups, the ITT group and the PD-L1 positive group. And this is a summary of the CheckMate 274 trial. The study was published in the New England Journal of Medicine, and the drug received approval by the FDA for treatment in the adjuvant setting in August 19, 2021. Now, before we move on, it's important to note here that we do not yet have overall survival benefit. So this remains unanswered up till today. And if you look on your right side, I just wanted to show the subgroup of patients who received previously neoadjuvant chemotherapy. You can see that those patients who received neoadjuvant systemic chemotherapy, they even derived greater benefit from adjuvant nivolumab, again, going back to the concept of sequential efficacy that we saw previously in the metastatic setting. Perhaps this is now translated into the neoadjuvant and adjuvant setting. Now, important questions remain. Do we accept disease-free survival as an endpoint? Well, FDA approvals in breast cancers, colorectal cancers, GIST, melanomas, and RCCs have all been based on disease-free survival endpoint. Besides, the ODAC consensus suggests that a disease-free survival benefit represents clinical improvement only if the degree of benefit outweighed the toxicity of adjuvant therapy. Now, in CheckMate 274, the drug was well tolerated and the health-related quality of life was actually maintained. Now, if you look at this table, you can see the advantages and disadvantages of using disease-free survival as an endpoint. In terms of advantages, you can see that disease-free survival endpoint is generally assessed earlier and requires a smaller sample size compared to trials looking at overall survival as the primary endpoint. In terms, besides, it often depends on qualitative and objective assessments. In terms of disadvantages, it is subject to assessment bias, particularly in open label studies. But this trial was actually double-blinded trial where the timing of assessments were well balanced and non-cancer deaths were not censored in order to minimize the risk of bias. Longer follow-up again and overall survival benefit are actually needed to confirm these findings. But in the meantime, there is definitely a certain group of patients who could derive benefit from adjuvant nivolumab while avoiding the risk of overtreatment in some other patients. Now, how do the results of IMvigor010 compare with that of CheckMate 274 trial? Well, IMvigor010 was the first adjuvant trial to be reported to date in urothelial cancer. And of course, this was reported as a negative study. And I think here we need to be very careful about cross-trial comparisons because there are very important differences between these trials. IMvigor010 actually compared atezolizumab, which is a PD-L1 inhibitor, against observation. The primary endpoint in this trial was disease-free survival in the ITT population as shown here. And as you can see here, the median disease-free survival was actually 19.4 months in the atezolizumab arm versus 16.6 months in the observation arm for a hazard ratio of 0.89. Now, if you look at the interim overall survival benefit here, you can see that the hazard ratio there was 0.85. So this was actually thought to be a negative study. However, we need to take here a closer look at the observation arm, which seemed to perform better in this study compared to the CheckMate 274 trial. This raises the question of whether patients were more likely to drop off the study if they knew they were on the observation arm. Furthermore, it's possible that those patients actually included in this trial were those with very high risk disease, which could also potentially explain why did they perform worse in this trial. Now, again, the safety summary of this is in line with expectations, grade 3 or 4 treatment-related adverse events occurring in around 35 to 37% of patients, more or less similar to the previous drug. And with regards to disease-free survival benefit by PD-L1 status, there was no benefit in both PD-L1 positive and negative patients. Again, this is not consistent with the previous study. And on subgroup analysis, you can see this negative trial not being driven by any particular endpoint. If you look at the forest plot here, this trial and the checkmate trial are not actually consistent. Now, when we think of high-risk patients, we really need to look at patients who are at an increased risk of relapse, not whether they express certain biomarkers in the tumor that was removed. Now, ctDNA is something we are hearing a lot about these days. ctDNA is about using a personalized approach where you perform whole exome sequencing on the primary tumor that was removed. You can then track ctDNA positivity in around 40% of patients in the adjuvant setting after removal of the primary tumor. And if you are ctDNA positive, you have a very high risk, 90% chance of relapse. I think this is a much better way of identification of high-risk patients compared to the PD-L1 biomarker. And there is actually some data showing that in ctDNA positive patients, there is a suggestion that there is a survival benefit from adjuvant atezolizumab. And you can see here that the dark blue is ctDNA positive patients treated with atezolizumab. Dark red is ctDNA positive patients treated with best supportive care. So again, ctDNA is really evolving in urothelial cancer. Now, ctDNA positivity identified high-risk muscle-invasive bladder cancer likely to derive DFS and OS benefit from adjuvant atezolizumab, whereas ctDNA negative patients have a lower risk of relapse and are unlikely to derive benefit from adjuvant atezolizumab, suggesting that perhaps they may be spared adjuvant therapy. Now, again, looking into the future of adjuvant therapy in bladder cancer, the IMvigor-11 is actually looking into this specific population of patients with ctDNA positive disease. And these patients are then randomized into adjuvant atezolizumab versus a placebo. Perhaps this is the way into the future of adjuvant therapy. Now, these are quickly the conclusions pertaining to adjuvant therapy in urothelial cancer. So nivolumab is actually now approved by the FDA in the adjuvant setting in high-risk patients with muscle-invasive bladder cancer. Now, what about neoadjuvant immunotherapy in urothelial cancers? Well, there is some data previously showing that perhaps neoadjuvant immune therapy may be more effective than in the adjuvant setting. So in the adjuvant setting, we've already removed the primary tumor, but there is still present in a certain subset of patients micrometastasis present. While comparing to neoadjuvant therapy, the primary tumor is still there. So perhaps theoretically, we may have more neoantigen-directed clones that may help perhaps clear up the micrometastasis. And there is actually some evidence to support this phenomenon. This is a very nice trial performed in patients with melanoma where they compared neoadjuvant versus adjuvant ipi-nivo. The trial here, it's important to note that it was not actually designed to detect a clinical benefit, although there was actually a small benefit demonstrated in this trial. So the trial nicely showed that with neoadjuvant immunotherapy, there were many more new clones and even expansion of pre-existing clones, suggesting that perhaps neoadjuvant immunotherapy may be more effective than the adjuvant treatment. So these are briefly the neoadjuvant immunotherapy trials. These are 4 trials, either in monotherapy or in combination. And this slide here summarizes all of these trials. As you can see here, with a single agent or with monotherapy, the response rate ranges from 20 to 30%, a bit higher with combination treatment. But whenever we look into all of these trials, we need to consider a couple of things. First, the primary endpoint pathological CR is not always consistent in these trials. So some of these trials used a T0 endpoint, others used TIS that may be different. And some patients actually do not make it to surgery. So in some trials, they took the evaluable patients, while in other trials, even though patients progressed, which precluded them from surgery, they were excluded from the analysis, which I think is totally wrong. Another important point to consider is that some trials had what we call a T2 bonus, that if you include T2 patients in your trial, you get some pathological CRs for free. And actually some monotherapy trials included T2, T3 patients, whereas other trials like the Nabucco trial, for example, included only T3 patients. However, again, all these findings need to be confirmed in randomized trials. Now, obviously, a very easy combination is the use of chemotherapy in combination with immunotherapy. So this is a nice trial where cisgem was given in combination with durvalumab. The primary endpoint of this trial was not pathological CR, but rather event-free survival at 2 years. Now, if you look at this trial, you can see that the overall pathological response here was not overwhelming for this trial. The pathological CR rate was 34%. Downsizing occurred in 60%, more or less similar to what we would expect with chemotherapy alone. However, when we look at event-free survival, you can see that the event-free survival at 2 years was 76%. So it is probably possible that the PCR is separated from the event-free survival. Again, we need randomized controlled trials to confirm these findings. Now, if you look at patients who responded to neoadjuvant immune therapy, so basically in all the responders to neoadjuvant immune therapy, plasma ctDNA is cleared, whereas in non-responders, ctDNA remained positive prior to radical cystectomy. Now, if you look at the progression-free survival, you can see an enormous difference between patients who cleared their ctDNA versus those who did not clear their ctDNA. So this is quite prognostic. Now, this is a very recent trial, a randomized phase 3 trial, where only the first 17 patients were actually included in the analysis. You can see that there is a bit more of toxicity in patients receiving the triple combination, also considering that the majority of these patients had T2 disease. Tumor downsizing occurred in 9 out of 17 patients, whereas PCR in 6 out of 17 patients. Again, this is only preliminary data recently presented at ASCO GU. We need to await the final results. And last but not least, with regards to bladder cancer treatment, in those patients who are refusing radical cystectomy, definitely definitive chemoradiation is possible in those patients, provided we have better induction regimens and better monitoring via ctDNA. And perhaps in the near future, many more patients may be spared radical cystectomy. So the ENDBLADE trial is actually looking into this. And evaluating the possibility of sparing the patients radical surgery. And these are my conclusions for the neoadjuvant immune therapy in urothelial cancer. Neoadjuvant chemotherapy is still the standard of care up till today. And data is ongoing to further evaluate the role of neoadjuvant IO in urothelial cancer. We move quickly to upper GI cancers. So again, these are highly immunogenic, specifically the MSI high upper GI cancers. Now, we have multiple trials that have evaluated the role of adjuvant and peri-adjuvant immunotherapy in upper GI cancers. We have the ATTRACTION-5 looking at chemotherapy with or without nivolumab. And with regards to neoadjuvant trials, we have the KEYNOTE-585 looking at cisplatin-based chemo with or without pembro, the MATHORN phase 3 FLOT with or without durvalumab, the DANTE study FLOT with or without atezolizumab, and so on. We have some preliminary data, but we do not have yet the final results with these trials. Now, these are the standards of care in operable esophageal cancer, so in patients with squamous cell cancers. As we all know, the treatment algorithm is either a neoadjuvant chemoradiotherapy followed by surgery, and then in patients with residual disease in the resection specimen, you go for adjuvant nivolumab, or you can go for definitive chemoradiotherapy in squamous cell cancers. Whereas in adenocarcinomas and GE junction cancers, we have two options, either perioperative FLOT or neoadjuvant chemoradiotherapy followed by surgery. And in those patients who have residual disease in the resection specimen, you consider adjuvant nivolumab. So this is the cross trial that we all know, a comparison between neoadjuvant chemoradiotherapy followed by surgery versus surgery alone. So the neoadjuvant chemoradiotherapy is as simple as it can be, a little bit of more than 40 grays in conventional fractionation with weekly schedule of carboplatin and paclitaxel in tolerable doses. And what the survival curves actually have shown us here is that there is a sustainable survival advantage in patients who receive neoadjuvant chemoradiotherapy followed by surgery versus surgery alone. And this benefit was more pronounced in the squamous cell carcinoma cohort compared to the adenocarcinoma cohort, but at the end of the day, both of them benefited. So this is a key justification for using this methodology of treatment in this category of patients. So in both squamous cell cancers and adenocarcinomas of the lower esophagus and GE junction, neoadjuvant chemoradiotherapy followed by surgery is the standard of care based on the results of the CROSS trial. However, patients who have residual disease in the resection specimen are at an increased risk of recurrence. This occurs in around half of cases of squamous cell cancers and around 75% of patients with adenocarcinomas. And perhaps these poor complete response rates in adenocarcinomas are one of the reasons why many oncologists prefer to give the perioperative FLOT in GE junction cancers rather than a neoadjuvant chemoradiotherapy followed by surgery. Now, to try to improve the outcome of patients who are treated with neoadjuvant chemoradiotherapy followed by surgery and who are at an increased risk of recurrence, specifically who have residual disease following trimodality therapy, the Checkmate 577 randomized patients to receive either a nivolumab for 1 year or placebo. Now, in this trial, the majority of patients had adenocarcinoma and were non-Asians. And the primary endpoint of this trial was disease-free survival. Again, the baseline characteristics were more or less well-balanced between both treatment arms. Now, as for the primary endpoint of the trial, you can see here that adjuvant nivolumab for 1 year significantly improved median disease-free survival in the overall population. And this is now established as the standard of care in this category of patient. Median overall survival has not yet been reported up till today. Now, distant metastasis-free survival was also significantly improved with adjuvant nivolumab. And speaking of safety, again, no major safety signals were detected in this trial. The safety profile and tolerability was consistent with that reported in previous studies. Likewise for immunologic toxicity. Now, as we might expect, because squamous cell cancers are more sensitive to CPIs, checkpoint inhibitors, compared to adenos, there was more benefit in the squamous cell carcinoma cohort, but also adenocarcinoma patients benefited. Now, in Checkmate 577, PD-L1 was not used for patient selection, but stratification was done by TPS. And we know that because TPS is less useful in adenocarcinoma patients and that the majority of patients in this trial were dominated by adenocarcinoma patients, there was actually no significant interaction between TPS and survival in the study. However, on subgroup analysis, the only patients who benefited were those with a CPS score greater than or equal to 5. However, we do not use this benchmark for patient or treatment selection because this is only a subgroup analysis. Now we move quickly to localized gastric cancers. Again, this is the approach to treating localized gastric cancers. So the standard of care is to use perioperative chemotherapy with FLOT. And in those patients who had to undergo surgery for whatever medical emergency like massive bleeding or gastric outlet obstruction, then postoperative chemoradiotherapy is an option. And in gastric cancer, currently, up till today, we do not have immunotherapy in the localized setting, even though data is coming and you know, the trials are ongoing and preliminary data is quite impressive, specifically in MSI high patient population. Now, going quickly and speaking of MSI high patients, we know that MSI high patients have a very favorable prognosis in localized setting, and several retrospective analysis from different trials in Europe showed that really there was no true benefit from perioperative therapy in this category of patients. So an important question remains, should we treat these MSI high patients according to guidelines with perioperative FLOT or with neoadjuvant chemoradiotherapy followed by surgery, or is it of no benefit because they on their own have favorable prognosis with surgery alone? This actually remains an ongoing debate. Now, some MSI high patients were included in the ongoing Dante study, which is evaluating the combination of perioperative FLOT and the PD-L1 inhibitor, atezolizumab. And if you look at the subset of patients with MSI high disease, you can see that the objective response rate or the overall response rate was quite good with this combination. And actually up to 50% of patients receiving FLOT and atezo achieved complete pathological response, but also 42% of patients with FLOT alone achieved complete pathological response. So it is not entirely true that this is a chemo-resistant group of patients. Now, this is my last slide, looking forward into the future of treating MSI high esophageal and gastric cancers. The NeoNepiga study organized by the French network is actually giving MSI high patients with gastric and lower esophageal 12 weeks of neoadjuvant treatment with ipi-nivo, after which patients undergo surgical resection. And the preliminary reports demonstrated around 60% complete pathological response rates. However, we do not use this outside of clinical trials. This is still under study, but it is worth mentioning because the complete pathological response rates were quite astonishing here. This is a brief summary of the ongoing trials that we are still awaiting their results in the early stages of gastric and lower esophageal cancers. And these are my conclusions. Again, nivolumab demonstrated a statistically significant meaningful improvement following neoadjuvant chemoradiotherapy followed by surgery in patients with residual disease in the resection specimen. And this is for the first time we have adjuvant immunotherapy in esophageal cancer demonstrating such a benefit in this category of high-risk patients. And with that, I would like to thank you for the kind attention and happy to take any question.
Thank you very much, Professor Sally, dear Dr. Sally. So very clear, very nice. There is a question from the audience from Dr. Amin Nas. Immunotherapy as neoadjuvant is better than adjuvant. So for how long we can use it as a neoadjuvant? We will ask you, Dr. Sally, then after we'll ask Dr. Fadil Karak about that.
Sure, this is a very important question. Well, that depends on the different trials that were evaluating the role of neoadjuvant immunotherapy. So up till today, we do not have level 1 evidence to use neoadjuvant immunotherapy in bladder cancer or in upper GI cancers. Based on the trials that I have just discussed, the duration or the timing of neoadjuvant immunotherapy differed between the different trials. So some of them used 3 cycles, others used 5 cycles, some used 6 cycles. So really that differed based on the trial design. But again, I would like to re-emphasize that up till today, we do not have data. The data is really encouraging, and the science behind the use of neoadjuvant immunotherapy is also encouraging for investigators to go and look into this because of the more targeting of the circulating tumor cells in the circulation when you have an intact primary. But again, we are awaiting the phase 3 trials. We do not have them reported yet.
So I'll move to Dr. Fadi. I think he has a more clear response. Are you with us, Dr. Fadi? Fadi. Okay, I might answer this question. And some indication like lung cancer, surgeon do not like at all to give the patients more than 3 cycles of neoadjuvant chemotherapy. So usually they ask only 3 cycles, not more, and they say that it's harder to operate if the patient received more than 3 cycles. And in the trials, it was also the same, 3 cycles of chemoimmunotherapy. So I'm not sure that neoadjuvant when there's a combination, usually we might expect to have responses slower with immunotherapy compared to chemotherapy, as we have seen in many first-line setting when 9LA4 in lung cancer and other. So yes, maybe if immunotherapy alone, we might have longer duration. But when we do a combination immunochemotherapy, the duration should be always 3 cycles in lung cancer, for example. And we have to stick to the trials, as Dr. Asel said. We have to follow the design of the trial. In lung cancer, 3, in GI-GU, we don't have approval. Thank you, Dr. Asali. Very nice.
Thank you so much.
Thank you. You agree. Now, I would like to ask, the ctDNA is now really taking an important place. And I know that you are using it, for example, in some colorectal cancer, you are using it to define the need of adjuvant treatment. So can you brief us, since you are talking about the GU and GI, where really is it approval? I know that in colorectal stage 2, it's not, while in stage 3, it's so give us a brief.
So yes, thank you for that. Really an important question. ctDNA is now being evaluated in nearly all malignancies, and it's taking a big role now in bladder cancer, but we do not have yet the data to start using it till the IMvigor 11 is out. Now in colorectal cancers, yes. The place where we are using ctDNA is in patients with like high-risk stage 2 that you're not really sure whether you should give adjuvant chemotherapy or not give adjuvant chemotherapy, and in favorable stage 3A patients, you can use the ctDNA to see if the patient has ctDNA positive, then adjuvant chemotherapy is indicated. If he has ctDNA negative, then you can spare him adjuvant chemotherapy. And in another scenario where you can consider, specifically in colorectal cancer, when you have oligometastatic stage 4 patient, whereby you go primarily after the primary and the metastatic site. So here in this setting, we don't know whether we should again give adjuvant chemotherapy or not. So for this reason here, again, we resort to use the ctDNA to guide our decision. If the patient is ctDNA negative, we will spare him the toxicity. If he's ctDNA positive, he will go to 6 months of treatment.
So just to clarify for the audience and for myself also, we do the ctDNA before starting the treatment after the surgery.
Yes.
But we can repeat it later on. If it's positive, can we repeat it, and when?
Well, there is really no guideline as to when to repeat it, but you can consider repeating it at 2 to 3 months interval and check. But again, beyond that 2 to 3 months interval, again, if you are going ultimately to decide on adjuvant chemotherapy, here the role of adjuvant chemotherapy becomes questionable. But if you repeat the ctDNA, again, you do not have level 1 evidence to tell you that you need to give your patient chemotherapy. Like if, for example, your patient has a detectable ctDNA positivity 9 months following the surgery, what would you do? You would just need to wait because he has no evidence, no clinical evidence of disease. So at this point, repeating the ctDNA is still under investigation, because if you do it, it will the patient will ultimately end up in an anxiety state. You cannot know what to tell the patient what to do. So there is really no point in keeping on doing the ctDNA for a long period of time. We do the ctDNA post-op once, and if you want to do a certain clinical trial or a certain follow-up under clinical study, you can do it, but not for clinical purposes at the later stages.
Dr. Sally, an excellent presentation, very scientific content. Thank you very much, and very nice discussion. Thank you, Sally.
Thank you so much.
Since there is no more question to Dr. Sally, Professor Sally Tamraz, we will move to the presentation of Dr. Hamdi Abdulazim about the role of immunotherapy in early stages of breast cancer. We tackled today the early stages, and it's really amazing to have all these options with us. Dr. Hamdi is well known. He's a professor of clinical oncology and chairman of Qasr Al Aini School of Oncology. He had an unfortunate, he had an urgent issue. So today at today noon, he made the recording. So we'll have a recorded presentation. Please, Vanessa, if you can start.
So good evening, my dear colleagues and friends. My name is Hamdi Abdulazim from Cairo University. It's my pleasure to join your meeting today. I wish to thank my friend Dr. Fadi Farhad for giving me the opportunity to be with you today. And I apologize for being unable to attend physically or even virtually because of a prior commitment, but I try to make the assignment that was given to me by Dr. Farhad quite simple for everybody. My task is to discuss with you the current situation in the management of early-stage triple-negative breast cancer. And I'll get you straightforward to a real case in our practice here, and try to put things together during the treatment journey of this patient. That's my disclosure. To start with, this young lady, 39 years old, she was referred to our institution with a bit unusual presentation, left axillary and left supraclavicular lymph nodes. And after the clinical examination, nothing was really felt in the breast, but we had to go for a mammography, which was not conclusive. The ultrasound actually, it could raise a strong doubt for the presence of malignant nodal masses in the left axilla, and we had the guided biopsy and the insertion of 2 clips. That's the usual thing we do. Our radiologists, they do when they have something related to the breast. And the pathology showed duct carcinoma grade 3 high grade with triple negative breast cancer phenotype, a very high KI, 67-90% actually. That's how it looked in the ultrasound. 2 masses, as you can see here and here, and they were thickened cortex, again, quite evident in the 2 ultrasound images. Then we had, I'm sorry, then we had an MRI which could show why the situation is a bit unusual. A very deeply seated left breast mass, as you can see here. That's the breast. That's the most deep part of the breast, very close to the pectoral muscles, and that's the lymph node. So actually, it was not 2 axillary lymph nodes that was interpreted by ultrasound, but we have a lymph node here, and we have a breast mass here. And the PET scan actually did not reveal anything else. Here is the supraclav, here is the left axilla, and here is the left breast mass. Importantly, the disease already advanced in terms of TNM stage. It is stage 3C because of the presence of the supraclavicular lymph node. Nevertheless, as you can see, there is no high tumor burden. As you can see, that the diameter of the disease is not big, and there was no extra-regional metastasis. So in essence, that's a stage 3C in a very young lady, 39 years, high-grade triple-negative breast cancer. And a very usual question here, do you need a BRCA to determine the BRCA mutation status? And the answer is, of course, yes. But I just want to review with you these data of how you can predict the risk of BRCA mutation in this patient. These data came from the MD Anderson Cancer Center more than 13 years ago. And they reported that in young women up to the age of 50, irrespective to family history and irrespective to the disease phenotype, if their age is 40 years or less, the estimated BRCA mutation prevalence is around 11%. But look at patients like ours. If she has triple negative and below the age of 40 years, like our patient, the incidence of BRCA mutation is pretty high, irrespective to family history. Our patient did not have any relevant family history. The outcome will be expected. The BRCA mutation will be something like 23%, which will drop to 17% if the age is up to the 50 years. Anyway, here we are. That's the situation in the MDT stage 3C. How do you wish to manage? Of course, the management should be neoadjuvant treatment, no doubt about this. Why neoadjuvant treatment in triple-negative breast cancer, even in earlier stages? Because first, neoadjuvant chemotherapy can significantly reduce the risk of mutilating surgery, meaning mastectomy and axillary lymph node dissection. Secondly, we knew during the last few years that neoadjuvant chemotherapy strongly serves for prognostication in triple-negative breast cancer, so much that if your patient achieves PCR, like in the blue curve, then the prognosis is pretty well, while if your patient fails to achieve PCR with residual disease, you will lose something like 50% of these patients at 5 years. So your aim in such case, how you pick and choose your chemotherapeutic regimen, certainly it should be the one that will give you the highest possible PCR. Here we have very favorable event-free survival, and we have the highest possible rate of less intensive surgery. And importantly, for those patients with residual disease, where you have poor prognosis, if they have residual disease, then you may try your lucky star by adding a new systemic adjuvant treatment, actually, that may be able to improve the event-free survival in these patients, what we call now as response adapted trials. So let's focus first for what is the chemotherapeutic regimen that would give you the highest possible PCR. We have known from the meta-analysis of Cortazar, published around 10 years ago, that in triple-negative breast cancer during the neoadjuvant setting, if you give AC and taxane-like regimens, you will have a PCR rate in 1 out of 3, which is not bad, but that is the platform that we have to compare against all the way. The second important question, would platinum, addition of platinum to anthracycline taxane regimen improve the treatment outcome during the neoadjuvant phase of triple-negative breast cancer? Before we answer, we were under the impression that probably the platinum will improve the PCR rate in patients with BRCA mutation. But let's have a look on the kind of data we have at the present time. That's one of the German study, neoadjuvant studies, actually utilizing anthracycline plus paclitaxel with or without carboplatin. That's the GPAR-62. The PCR rate you can see improved dramatically by more than 15% if you add platinum to no platinum. And in this particular trial as well, there was a significant improvement in the event-free survival with a very impressive hazard ratio of 0.56. Importantly, the same group later, they provided the outcome of this study according to the presence or absence of BRCA mutation. So you can see on your right-hand side, patients with germline BRCA mutation, on your left-hand side, patients with no BRCA mutation. You can see that all the way, patients with BRCA mutation, whether you give platinum or you don't give platinum, that they have better PCR rate. So we understood from this study and from other studies that patients with germline BRCA mutation, triple negative, when you give them neoadjuvant chemotherapy with or without platinum, the PCR rate is always in favor of those with germline BRCA mutation. But importantly, you can see with the addition of platinum, especially in those with no BRCA mutation, that the PCR rate improves significantly, actually. So in this particular trial was very instructive to us to know that platinum is important to improve PCR rate in all comers, whether BRCA mutant or BRCA non-mutant, but it showed that the benefit actually was more seen in patients with non-BRCA mutation. And again, the addition of carboplatin was associated with significant improvement in event-free survival. Later, we have the brightness study, which was a phase 3 study, not a phase 2 like the other one. And again, once again, the addition of carboplatin to anthracycline paclitaxel significantly improved event-free survival and improved PCR rate. PCR rate jumped from 31 the classical with anthracycline taxane to 58 with the addition of carboplatin. And again, the benefit was more seen in patients with BRCA wild, not BRCA mutant. Importantly, and I like this very much, you can see that the hazard ratio for the improvement of event-free survival was very similar to the hazard ratio we have seen together in the Jeopard 6-2. So now we're pretty sure that when you add the carboplatin to your classical anthracycline taxane regimen, you will be able to improve the progression, the event-free survival, and you improve the PCR rate. You do less surgery. Certainly, we have level 1 evidence with this data. But you have to remember that when you add carboplatin, your patient and your team will suffer from more treatment-related complications, especially those related to hematological toxicities. The question is valid now with the presence of immune checkpoint inhibitors. Would the addition of immune checkpoint inhibitors increase over the already above 50% PCR rate when you add the platinum in triple-negative breast cancer? And before we embark on this question, I need just to remind you that in the metastatic triple-negative breast cancer, the benefit of immune checkpoint inhibitors was really seen, but it was only in patients with PD-L1 positive tumors. We have seen this in the IMpassion trial with Atezo plus nab-paclitaxel versus nab-paclitaxel alone, where you can see the progression-free survival is significantly better in PD-L1 positive, while there was a zero benefit in patients with PD-L1 negative population. Likewise, in the other positive study, which is the Keynote 355, that's the data of patients treated with pembrolizumab plus any chemotherapy. If the patient had PD-L1 CPS less than 1 or from 1 to 9, no benefit at all of pembrolizumab, while the benefit of pembrolizumab was only seen if your patient has PD-L1 positive, which is anything 10 or more by the assay of PD-L1. So in metastatic triple-negative breast cancer, yes, we had some success stories, but it is only limited to a fraction of the patients who are defined as PD-L1 positive. In this population is between 35 to 40%. So in metastatic triple-negative, the benefit of immune checkpoint inhibitors only in this fraction. So the question is very valid. Do you expect a better treatment outcome in the early stage of triple-negative breast cancer compared to the metastatic phase? Before I convince you with the answer, I wish to show you some lessons we learned from our colleagues and the pathologists, actually. And this is a very nice study from the Yale University pathology group. They brought the triple-negative breast cancer patients and they checked the tumor-infiltrating lymphocytes, the TILs, in the primary disease and the TILs in the metastatic lesion when these patients, they relapsed. And you can see in this what we call paired comparison, that's to say, from the same patient, you have primary biopsy and a biopsy from the metastatic disease. You can see that tumor-infiltrating lymphocytes, they dropped significantly in the same patient when you compare the primary versus the metastatic lesion. Likewise, the PD-L1 positivity was much higher in patients during the primary disease compared to the time they relapsed. What do we learn from that? We learn from that primary breast cancers are immunologically much more activated immunologically than there is corresponding metastatic tumors. And we learn that we may expect better treatment outcome with immune checkpoint inhibitors during the early stage of triple-negative breast cancer rather than the metastatic phase. Anyway, let's have this data in mind and check for the first large phase 3 study included more than 1,000 patients. They were all triple-negative breast cancer treatment with the combination of carbopaclitaxel plus AC with or without pembrolizumab, and it was the randomization was 2-to-1. This study had two primary endpoint, PCR rate and event-free survival. And you have seen this data several times before. Certainly, that the PCR rate was significantly better if you give pembro compared to the placebo. But and look at the carboplatin paclitaxel AC regimen. It is 50% plus. So now we're sure that if you give platinum, you can all the way have 50% plus as the PCR rate without immune checkpoint inhibitors. But with pembro, you improve that to 64%. The good news in this study that unlike the metastatic disease where PD-L1 negative, they have zero benefit of immune checkpoint inhibitors. In early stage triple negative breast cancer, the benefit was seen whether your patient is PD-L1 positive or PD-L1 negative. But importantly, the PCR rate anyway, whether you give pembro or no pembro, the PCR rate was always much less in patients with PD-L1 negative, triple negative breast cancer. Please remember this because we'll come to this piece of information later on. So we discussed the data of the keynote 522 with our patients, and her germline BRCA mutation came to be negative for mutation. So we started actually the treatment as an off-label indication because at that time pembro was not yet approved, and we started the very classical regimen of the 5-2 carboplatin pembro plus paclitaxel for 12 weeks, then AC every 3 weeks for another 12 weeks, and here we are. That is the baseline. That is 3 months in the middle. A very small residual disease, as you can see, and what appears to be a complete remission by PET scan by the end of the 6 months of neoadjuvant treatment plus pembrolizumab. And here we are. That's the MRI. Again, it is clinical and radiological remission of the disease. Importantly, we have primarily, as I told you, inserted 2 clips. And in the MDT, we discussed with the surgeon what kind of surgery you wish to do, especially she has no BRCA mutation and she's in complete remission. So the decision was to go for breast-saving surgery and sentinel lymph node biopsy. Our radiologist, she inserted the 2 wires immediately before surgery for the surgeon in order to help him to find the disease intraoperatively in the axillary lymph node and in the deep breast lump. And after wire localization, she underwent her surgery, and she received the pathology came to be PCR, and the patient was maintained with 1 year of pembrolizumab after finishing her radiotherapy. That's how it looks after her surgery. And later on, we knew in subsequent presentations of the 522 that the addition of pembrolizumab, as expected, could significantly improve the event-free survival with a very good hazard ratio of 0.63, which was highly significant, of course. And this was attained, this improvement in event-free survival, whether your patient had not negative or not positive, whether it is PD-L1 positive or PD-L1 negative. But please look at here that the absolute gain in PD-L1 negative was even much higher than those with PD-L1 positive disease. So another piece of information to tell us that the situation in early stage triple negative breast cancer is totally different when it comes to the role of PD-L1 negativity, where it is important for metastatic disease, while in early stage triple negative breast cancer, PD-L1 negative, they make a very relevant and significant benefit of the addition of immune checkpoint inhibitors. Another subgroup which was important to see the event-free survival for was the presence or absence of PCR. If you have PCR in your patient, whether by chemo or by pembro, the event-free survival is extremely favorable. And the superiority of pembro was not significant. It was absolute gain of around 1.9%. But the real benefit actually was seen in the bad group, in patients with no PCR, where the absolute gain at 3 years in event-free survival was very significant, around 10.6%. So the question in patients PCR, do you still need to keep your patients on pembrolizumab for 1 year, or you can stop at 6 months? Here, I don't have the final answer because two futuristic scenarios. Scenario one is that PCR will be more durable with immune checkpoint inhibitors versus with chemo alone. So by subsequent follow-up, you will see that the PCR, the Kaplan-Meiers of the patient's PCR will diverge over time in favor of pembrolizumab. What we call the quality of PCR is better. Do you have similar data on this issue? The answer is yes. We have seen that patients who achieve PCR with chemotherapy alone or chemotherapy with trastuzumab, that patients, the PCR with chemotherapy plus trastuzumab was much more durable. That's what you see in your right-hand side compared to patients who achieve PCR with no trastuzumab. But anyway, it remains to be seen because we have other scenario that the PCR will be equally durable whether you give immune checkpoint inhibitors or you don't. At this, if this was seen if this will be seen in the future, then you will give only pembrolizumab for the first 6 months. So the question now we have very, very, very impressive data to help us in the management of early-stage triple-negative breast cancer. The good thing is that it can help you in all comers, all patients with no biomarker selection. We have the platinum, which is able to improve the event-free survival with an absolute gain of around 8 to 10%. We have seen this in the brightness study, and we have seen this again in the JUPAR-62 study. So we're sure now that platinum will improve the PCR rate, will improve the event-free survival very significantly. The other good thing is that if you add to this platinum-based neoadjuvant regimen, if you add pembrolizumab, you will be able to further increase the PCR rate by 13%, and you improve the event-free survival, especially in those with no PCR, where in no PCR, the absolute gain is 10.6%. Once again, still what we lack at the present time is the performance of pembrolizumab in patients with the BRCA mutation. I guess the investigators with the 522 will provide us with this information in the near future. But if your patient has BRCA mutation, I don't see a reason why not to use this, because it applies for all comers anyway. Can you use other immune checkpoint inhibitors with other chemo, assuming a class effect? If the answer is probably not. We have seen the new triple PDLA study, which is called again Michelangelo study, that atezo plus carboplatin and nab-paclitaxel for 8 cycles versus the same chemo plus with no atezo. You have seen that the overall PCR rate actually was the same. It was not significantly better when you added atezo, whether in PD-L1 positive or in PD-L1 negative, whether in early disease or locally advanced disease. So that was a bad news actually, and we don't have full explanation of that. But I'll try to discuss with you some explanation. in a second. But importantly, as we have seen in the other study in the 522, that patients with PD-L1 negative disease, they have less chemo response compared to patients with PD-L1 positive disease. Keeping that in mind, please. And the other study to make life more complicated for us, again, with Atezo once again, and nab-paclitaxel once again, together for 3 months, then followed by Atezo plus AC versus the same treatment without Atezo. So here we have very good outcome. The PCR rate is significantly higher in favor of the Atezo versus chemo alone. And this again was seen whether in PD-L1 positive or PD-L1 negative. So how can we interpret these studies? Actually, first of all, we have to remember that the only negative study is the study that did not include the AC regimen in the neoadjuvant setting. So probably we need the anthracyclines in the neoadjuvant setting whenever you're trying to give immune checkpoint inhibitors. The second point that we need to emphasize here is the PD-L1 positive tumors. Again, you can see that patients with PD-L1 positive tumors, whether you give Atezo or no Atezo, the PCR rate is pretty high compared to patients with PD-L1 negative. So because of this data for PD-L1 positivity and how it can predict the PCR rate, in my group, we brought all the studies that related the PD-L1 positivity to PCR rate in triple-negative breast cancer, and we undergone meta-analysis and systematic review of that, and we found that the PD-L1 positive triple-negative breast cancer, actually they had a significantly higher likelihood of achieving PCR during the neoadjuvant setting of triple-negative breast cancer by chemotherapy alone. They are able almost to double the PCR rate if you have your patients PD-L1 positive. And importantly, in the studies that reported the long-term outcome in these patients, once again, in our meta-analysis, PD-L1 positivity was found to be associated with significantly better disease-free survival and overall survival compared to PD-L1 negative patients. So actually, PD-L1 negativity is a biomarker for a bad disease in early-stage triple-negative breast cancer, where it is associated with less PCR and less event-free survival and significantly inferior overall survival. And the explanation for that is actually we found when we have done transcriptomic meta-analysis to find that PD-L1 expression actually was a surrogate marker for the upregulation of the key immune-related gene expression, and hence this can be able to explain the higher PCR and the improvement of survival. Anyway, if your question, pembro plus chemo, should it be a standard of care in triple-negative breast cancer during the neoadjuvant setting as of today? My answer, yes. It seems yes, in my opinion, unless you have contraindication of its use, of course. Why is that? Because it does everything you need to see. It significantly increased the PCR rate, which is the major prerequisite for a better prognosis and less invasive surgery. And you achieve that in all comers, whether PD-L1 positive or PD-L1 negative. And importantly, again, it dramatically improved event-free survival in patients with residual disease, which have a very poor prognosis. As you can see, pembro in patients with residual disease improved the 3-year event-free survival by more than 10%. But still, you have to remember that, again, your patients with residual disease, in spite of the improvement with pembro, still they are they had much inferior event-free survival compared to those with PCR. So still at 3 years, you lose something like 1/3 of this population. Of course, you have to do something for these patients, and this something for these patients, we call it response adaptive trials in order to improve what you have achieved with Pembro in patients with residual disease. So patients with residual disease with no Pembro, they were here. With Pembro, they are still here. But those with PCR, they are much better. Here, you can think of the response adaptive trials. We have at the present time 3 of these trials. These trials are directed for patients whose response was no PCR. So if your patient with triple negative breast cancer, she has no PCR, you can think of the data that we gathered together from 3 studies called response adaptive trials, the CREATE-X and the EA1131 and the Olympia study. Let's first see the CREATE-X because it's a very famous study done by the Japanese group. The only caveat in this study was the sample size was pretty small, 900 patients, and it was not focusing on triple negative actually. They are focusing on HER2 negative, whether ER positive, HER2 negative, or triple negative breast cancer. And they brought a quite high risk population with residual disease after neoadjuvant treatment. The majority, they were not positive. And in the intent to treat population, the addition of capecitabine as an adjuvant treatment versus no treatment, which is the control group, could significantly improve the event-free survival and overall survival. But in the subgroup analysis, actually, this benefit was strictly seen in patients with triple negative breast cancer. And that's why this was put in the NCCN guidelines and other guidelines where they will advise you if your patient has residual disease to consider capecitabine. But in my opinion, here we have two things that I wish to remind you. First of all, that the capecitabine dose in this particular trial was pretty high, 2.5 grams per square meter per day, which we are not able to recommend actually in our patients in the Middle East and in the patients in the Western countries. It seems what we understood several years ago, that the capecitabine at this high dose is much better tolerated by the Asian patients in the Asia-Pacific region, the Chinese and the Japanese, rather than the rest of the world. So in our practice, we do not give this dose. We cannot increase the dose of capecitabine more than 2 grams. And the second thing that you have to pay attention in this study was the total number of patients with triple negative breast cancer upon which we are recommending this drug for everybody. It was only 286 patients with triple negative breast cancer. But anyway, you will find this in the guidelines. Later, 2 years later, the group from Spain, in one of their GECOM study, they have done the same exercise, but not in the same way, actually. Here, they brought everybody with triple negative breast cancer. So it was a more homogeneous group. And the number of patients with triple negative breast cancer here is 870 patients. But the caveat here, they did not bring really high risk population, as only 20% of the patients, they had residual disease after neoadjuvant chemotherapy. And they have a lot of non-negative population as well. Anyway, after finishing all the neoadjuvant and adjuvant therapy, they were randomizing their patients to observation or capecitabine at the recommended dose, which is 2 grams per square meter per day. And you can see in the lower panel, there was no improvement neither in disease-free survival or in overall survival, but in a subgroup, which is a very important subgroup actually, according to the subtype of triple negative breast cancer. You know, the majority of triple negative breast cancer, the bad disease of triple negative breast cancer is related to the basal subtype, which is around 75% to 80% of all triple negative breast cancer. But the non-basal, actually, they have more indolent disease. And in this subgroup, in the Spanish trial, you can see that the upper curve, which is capecitabine, was significantly better than observation. Would actually capecitabine be useful in triple-negative breast cancer in all comers or in only those with non-basal triple-negative breast cancer? I don't have an evidence-based answer, but let's see the third trial actually, which may help us to find the answer, which is the trial that compared platinum with capecitabine as a post-neoadjuvant treatment in patients with residual disease. That's the EA1113 study, one of the US intergroups. They brought patients with residual disease, high-risk population. All of them have neoadjuvant treatment, all of them triple-negative, all of them residual disease. And then they had first to do PAM50 analysis in order to see the basal versus non-basal triple-negative breast cancer. And they randomized the patients either to receive 4 doses of a platinum versus 6 doses of capecitabine, and always in the dose of 2 grams per square meter per day, not 2.5 grams. Anyway, the primary endpoint in this study was invasive disease-free survival in the basal subtype, because we know that the basal triple-negative, they are the most difficult to treat, and they relapse quite rapidly if they have residual disease. The study was supposed to include 562 patients with basal disease, but unfortunately, they only included a much less number of that. They included overall population of 400. Out of them, 78% they had basal disease. And that was a major caveat of the study, of course. And the other caveat actually is they did not compare the standard number of cycles in the 2 arms. They gave only 4 cycles of platinum versus 6 cycles of capecitabine, which in my opinion is not the best way to compare the efficacy of the 2 drugs in this difficult to treat population. Anyway, is platinum better than capecitabine? Is 4 cycles of platinum better than capecitabine in these patients? The answer is no. There was no difference in whether you give capecitabine or platinum in patients with basal triple-negative breast cancer, which was the primary endpoint of the study. But we have seen that in patients with non-basal subtype, the performance of capecitabine was much better than the performance of carboplatin. So in this population, the 3 years event-free survival was much higher in patients with non-basal, 69% versus 46%. And also they provided us with what we needed to confirm in the overall population of the study. The upper curve is non-basal, the lower curve is the basal, irrespective whether you give carboplatin or capecitabine. The prognosis in non-basal is much better than the prognosis of basal. Yes, we have seen that several times, but this study confirmed that triple-negative breast cancer, at least when it comes to prognosis, you have to segregate your patients into basal and non-basal, because basal subtypes, they are still, we don't know how to manage them in the post-neoadjuvant setting. Importantly, prognosis of basal triple-negative breast cancer is still poor, and importantly, majority of patients with BRCA mutant triple-negative breast cancer, they are basal. And that's why we'll find the study of the Olympia is very relevant, because here they brought patients with high risk to relapse with germline BRCA mutation, triple-negative breast cancer, or HER2 negative ER-positive breast cancer. They were randomized after finishing all the classical treatment, systemic treatment, and radiation therapy and surgery to receive 1 year of maintenance olaparib versus placebo. And you can see the vast majority in the Olympia study, they were triple-negative breast cancer. So you can consider this as a real study for triple-negative breast cancer with germline mutation we have seen that there was a very significant improvement in the invasive disease-free survival. Again, hazard ratio very impressive, 0.63 in favor of olaparib. And what was more impressive, that we had improvement in overall survival in patients with treated with olaparib versus placebo. Mind you, to find a study to confirm improvement in overall survival at a median follow-up period of 3.5 years, this is probably the first time we see this in the history of early-stage breast cancer, actually. So the final take-home message, we have at last very good news in this bad disease, the triple-negative breast cancer. We could confirm during the last few years the important role of carboplatin when added to anthracycline taxane chemotherapy during the neoadjuvant setting. We have the brightness, or have the GPAR-62. You improve PCR, you improve event-free survival, you have more toxicity. And again, another good news, with the pembrolizumab, you improve the PCR, you improve the event-free survival very significantly. Again, you have more toxicity. At the present time, the German group, they are doing the GEOPARDUS trial, which is repeating the same treatment design like that of Keynote 522, but with the use of atezolizumab instead of pembro. And the final analysis expected to be by the end of this year. Again, we have seen a successful introduction of PARP inhibitors in the adjuvant phase in breast cancer. You know, PARP inhibitors were the introduction was lagging in breast cancer, and now we have very good news in this area. And finally, and thank you for your attention, and big thanks to all my team.
Okay, thank you very much. Indeed, I skipped the first presentation, which was the quiz, because I knew that we'll have a long presentation, more than expected. It's 2 hours. I see there's some questions. No, since Dr. Hamdi Abdulazim is not with us, I invite you to send the question to Dr. Hamdi. He said he's ready to answer your question. Either you send it to Science Pro and we'll answer you using calling Dr. Hamdi, or you may contact him directly. With that, I would like to thank you all, to thank the speaker, Dr. Asali, Dr. Fadi Karak, and Dr. Hamdi for their nice presentation. And I would like to thank the audience for staying with us for more than 1 hour and a half. We are at 2 hours now. And finally, to thank Science Pro and their support. And with that, I thank you again and see you on the next session of ABC.